All right, I'm going to call the meeting to order. Good morning, everyone. It's 9 o'clock. Welcome to October. I'm sure to think that this has gone really fast this entire year personally. So we're going to start our meeting off with Will Losey. He's going to come up and do some presentations for us.
Good morning, guys. Perfect. I didn't really have a good STEMI run from up north, so I've only got two cases to go through today. Got a stroke from our up north cruise, and then a STEMI from our property here. First case is a 63-year-old male with a history of hypertension, BPH, 911 call for a male with possible stroke. EMS notified at 22:37, arrived on scene 22:56, departed scene 23:14, so 18 minutes on scene there. But we do have explanation for that coming up. Called a stroke alert prior to arriving at 23:41 and arrived at Clinton at 23:45.
Breakfast is coming. I just can't be there.
So on arrival, the patient was found standing in the bathroom after taking a shower. States that it's just a heat stroke. Nothing before, just needs to cool off. Left-sided facial droop, slurred speech, abnormal gait. It's interesting for a heat stroke. Walk to the couch, let EMS do their assessment. Noting to have abnormal grip, left weaker than right. Able to raise both arms, no drift. However, the left arm didn't make it the same height as the right. Moving that limb slower, slightly contracted at the elbow. Focus gaze to the right, but wouldn't move to the left when asked to do so. And try to take a drink of water there at the scene, spilled outside of his mouth. Stated that he had a headache all day. Last seen normal around 2100. Symptoms began at 22 per family. The VAN score and he's positive on that. Initially refused to go to the hospital. They had to have a conversation with get him to be checked out, which is what extended their scene time on that case. Patient monitored, 12 lead, was unremarkable. Sorry, very good. Safety felt to go sleep. They monitored him through transport, no change in his condition. And again, I called the stroke alert prior to arrival at the hospital. So it got to us at 23:46. Stroke one was called, take directly over to CT. Neuro page at 23:50, and they began their consult at 23:58. And at 12 after, patient was administered TK, 26-minute needle time. Patient was taken back over to CT for a CTA, head and neck, was negative for LVO, so arrangements were made to send him down to the hospital there. For his stroke evaluation, his MRI did not show any lasting ischemic damage, and the patient was discharged dual platelet therapy, which not any deficits. On this one, fantastic documentation, both of their Cincinnati pre-stroke scale and the bands. Pre-notification was done, clear documentation, the last known well and onset. Again, like the on-scene time was extended. And as Beth likes to say, this is a great example of how quickly we can do T and K when we have that solid, base of documentation from you guys when you're on your way, and that helps us immensely, especially establishing that baseline, the timeline. In the case, we had a 47-year-old male, history of hypertension, GERD, smoker, coronary artery disease, type 2 diabetes. This patient got called out for a male who had fallen and was unconscious. EMS call at 19:15, arrived on scene 19:29, departed 19:36, so 7-minute on scene time. STEMI alert called prior to arrival, 19:46, and they arrived at Terre Haute, 19:48. Upon arrival to the scene, patient was found in no obvious distress. Bystanders stated that the patient had fallen, was unresponsive for the last 2 to 3 minutes. A&O on their arrival was pale, diaphoretic. Patient was assisted to a standing position, pivoted to the cot. States that he was dizzy with that change in position. Complains of chest pressure, believes he's had heartburn for the last 3 days, had a syncope episode, dizziness, had no nausea. Placed on a monitor. Showed elevations in 2, 3, and V3 with reciprocal depressions in 1 and APL. STEMI alert was sent to Union by a bridge. 324 of aspirin given, 1 sublingual nitro. Monitored that their chest pain did decrease while en route to the hospital from 3 to a 0. I loved this in the report because this is one thing we talked about last meeting that we want to work on, going to be a goal for 2025. Union noted not to call a STEMI until they obtain their own EKG in the ER. So patient hit the ED in 1954, 1958, EKG showing inferior STEMI. 2048, made it to cath lab, 2110, ballooned open. First medical contact, reperfusion of 100 minutes, stored balloon of 76 for the facility. This one was tough to pick out. See the RCA there, totally occluded. Nice and open back up. Highlights, opportunities. They called a STEMI alert at 1946. Cardio wasn't paged until after the EKG of the emergency department in 1958. It ended up being a 12-minute delay. If you look at your 100-minute first medical contact reperfusion time, 12 minutes gets us underneath that 90-minute goal. I did look back for the year of the pre-hospital notifications for STEMI alerts. We had 14 cases that were not activated prior to their arrival to 9 where they did. So that's some place I think we've got some ground that we can make up and cut down on these times overall.
Do you guys wait for the second?
The biggest thing that I've gotten is the cardiologist. So currently, because we have the 2 different cardiologist groups in Terre Haute, if we don't know who to call, they don't call until the patient arrives at the hospital and they find that information out. When I look at 14 to 9, I have a hard time believing that that's been the case, 2/3 of the time. Sure that it plays into some. I think there's probably some hesitancy for docs wanting to activate cardiology in a cath lab team without them making their own call. So I think we just got some work to do on streamlining it.
In my personal opinion, part of it is, familiarity, getting used to the medics. The medics are newer, the doctors don't know them as well, and they just don't trust sometimes. And I think we need to work on that for sure, on both sides.
And there's certainly been a lot of turnover
There is.
in our physician group.
Absolutely.
Lots of new docs.
I think we can make it better though. I really do. So,
Yeah, that's something 2025, we're gonna fix it.
Thanks,
One of
Will.
my main
Thank you very
focus.
much.
Thanks.
Tina's up next with our trauma report.
Oh, I can get loose here.
Hey.
Okay, good morning. We have 2 cases. One of them, when I was putting it together, I didn't see this, but I'll just pass this as a picture of the car from the first case. It's a El Camino is what it is.
It's an old El Camino, isn't it? Like a
59.
59, yeah. I thought it was an antique.
Yeah, it's really old. All right, so this was an 83-year-old
Yeah,
gentleman using a VA.
To me, that's not old.
911 call came in at 1323, at the 1324. En route 1324, it's on the scene at 1329, departed at 1402. Sorry, I didn't put the picture in the presentation, I didn't see it before. But they had a delay at the scene just to get him out of the car. They departed the scene at 1402 and arrived at Union at 1415. Call to dispatch was a minute, dispatched en route was 0 minutes. They were on scene for 33 minutes. Depart to arrival was 13 minutes, total time was 52 minutes from the 911 call to arrival. So the EMS was dispatched to the scene, two vehicle accident, said El Camino versus car, but I don't know, I just put it in there because that's what they said. El Camino, if you don't know, for some of the younger people, maybe it's a kind of a truck, but it has a car front end, kind of maybe, when you say mid-size.
It's real flat and real low to the
Yeah,
ground.
yeah, and the cab is very, pretty small, like a smaller mid-size maybe. Anyhow, and it was a 59, so that kind of added to some of the problems, so it didn't have some of the near safety features that we have now. The patient on arrival, patient advised he was driving 40 miles an hour in lane and an oncoming car came into his lane, hit him and his left front panel. There's no seatbelt, no airbags because of the year it was, they weren't required. The steering wheel is hard with no padding. And if you've ever been in one of those, or you can kind of see in that picture, it's a very rigid metal, steering column. So, there was heavy damage to the front door. They had to cut the door off to get him out. And they couldn't take him out the passenger side because it's like a bench seat, some of them, because of the, stick. It has a really long metal stick shift in it. So they removed him from the car, put him on the backboard. No loss of consciousness. He had no pain in the head or upper back. He had pain in the lumbar area. It increased with any movement. Left knee and generalized abdominal tenderness. Backboard was removed due to him complaining of increased pain in his back. And he refused a seat collar because he said he couldn't breathe with it on, and he refused an EKG because he didn't like the sticky things. Vitals were 1.456, pulse 68, rest 18, sat was 94, GCS was 15, he was alert and oriented ×4. The exam in the ambulance, he had a skin tear on the elbow, bleeding was controlled. He had a contusion in his left upper abdomen and lower chest, and he had positive pulses in all of his extremities. They started a 20 gauge, gave him some saline. He was on FEF. They called on the IHERN and it was to Union EMS trauma 2. Pre-arrival note just said auto accident, driver's side, no intrusion, chest pain, left rib and left knee pain. They called a trauma alert level 2 at 14:15. This is just our criteria, and he would have met for a rapid deceleration. For a level 2. Patient arrival 14:21. Vitals at that time on arrival is 97.5, 66.20. His blood pressure was 81.45. That was 85. That was on 2 liters and GCS was 15. So he was upgraded to a level 1 at 14:27 due to the hypertension and hypoxia. Trauma surgeon arrived at 14:50. He was alert and oriented on arrival. I was actually here for this one. Was complaining of left knee pain and difficulty breathing. He had bruising over his left hip and some scattered abrasions. It was a decent, some decent bruising. It was very obvious. They gave him, we started IV fluids and gave him blood transfusion. We gave him 1 unit completed, and then he had half a unit going when he was transferred later. Started some norepi. His blood pressure was kind of, it was kind of jumping in a little labile. At one point it was down to 68/39, rest for 23/31. And that was on 10 liters high flows. That was 89 to 95%. Gave him antibiotics, except for pain, as tetanus. EFAS was negative, except the left upper quadrant was equivocal, which I thought meant equal, but apparently it means questionable. I learned something every time I do one of these. C color was placed on arrival. He didn't argue with us about it. We just put it on. They anchored her fully at pink tinge urine. The doctors put in an art line. His injuries, he had some pulmonary edema, trace left pleural effusion. He had left rib fractures that were suspected. CT of the head, there was no acute changes. CTA of the chest, abdomen, and pelvis showed minimally displaced fractures posterior at the left, 2nd through 8th ribs. Minimal displaced fractures involving the body and the left scapula. Mildly displaced comminuted fractures involving the left superior and inferior pubic rami. Non-displaced, minimally displaced fractures of the iliac wings and the left anterior hemisacrum. Small amount of suspected hemorrhage in the left hemipelvis, causing slight rightward displacement of the urinary bladder. Non-displaced oblique fracture left L1 transverse process, small left pleural effusion, patchy areas of density, and molecular lobate that was related more to trauma. No fractures in tib fin. C-spine showed fractures of the posterior 2nd, 3rd, 4th, 5th, and 6th ribs. Non-displaced fractures of the medial 3rd of the left clavicle. And a radius and ulna because he was complaining of pain in that. There were no fractures. Labs, his white count was just barely elevated. BUN was 30, creatinine was 1.88. ABGs on 70%, was pH 7.304, PO2 was 52. Bicarb was 18, SAT was 83%.
You'll see again anyway, same thing.
I got a call from the radiologist, of course, about the x-ray results, that he had 2 sets of pelvic fractures, front and back, and 8 rib fractures. Trauma was there, recommended transfer to a level 1 trauma center because of the multi-trauma injuries. And diagnosis was hypotension, MCV, pelvic fractures, ramus fracture, rib fractures. We had started the 2nd unit of blood that was still infusing on transfer, and he went to Methodist, and his total ER time was 3 hours, 48 minutes, which is over what we want to see of 120 minutes. I went back and looked. We didn't get any follow-up from Methodist, but I did see that he had actually been readmitted afterwards, but not for trauma. He's at a local SNF for rehab. He had a recent hospitalization for an unrelated surgery. This poor guy, he went through all this, went to rehab, or went up to Methodist, was there for a couple of weeks, went to rehab, and then he had a gangrenous gallbladder and had to come back in for that. I'm like, poor guy. But the x-rays from this last day showed that he had rib plating. He had 5 ribs plated, had some pretty decent sized hematomas over the left flank and left hip. One of them was 14 by 6 or 14.6 by 8 by 3.1. The other was 7 by 3. Decent size. We didn't see them here, so I don't know if they were just starting. Like I said, because we did the fast, we did the CAT scans, there was some questionable bleeding, but we couldn't see where it was coming from, and we couldn't see what was causing this blood, dropping his blood pressure. It wasn't that obvious. So at some point, he really bled a good bit. So just because I like pictures, this is a picture of the rib plating that they did that showed on the films when he was admitted here. Yeah.
It's almost like a little, almost like a grommet in the sides, and then they put that little metal piece.
Yeah, I mean, it's really cool because you would think, oh my God, to look at that, you think it hurts so bad. But when you go up and follow up with these patients after they've had that done, they'll tell you that they've got some incisional pain, maybe some from the chest tubes that they have to put in. But the acute pain that they had from those rib fractures has dissipated. It's amazing. That's all I got on him. Anybody got anything?
So we screwed up several times here in the ER. He should have been a level 1, like the minute we got the IHER. And 3, almost 4 hours is just not acceptable. He should have been in and out our door in 2. But this is a case that is perfect. So we preach mechanism of injury to pre-hospital and in the ER, and we are just some days speaking to a wall. But this is the perfect example of why it is so important to consider the mechanism of injury. Because if you go back to the slide with his injuries and his labs, that one. Look at those injuries. We know he was in an old car, so we know it wasn't made of plastic and aluminum, right? He had no seat belts, no airbags. So you can look at those injuries. Now, I understand that we're a Monday morning quarterback, but I can look at those injuries and tell you that he hit that steering wheel and that dash. And I don't know, was the windshield start or anything? He probably went
I
side.
believe so.
Okay.
Yeah.
So you can tell that he went up and over. So think back to basic EMT or first responder when it talks about here's the type of injury, here's the type of impact, what kind of injuries would you suspect? He's got almost all of them. And if you can break the first or second rib or the sternum, that's a lot of force. And he did it all the way down on both sides, front and back.
But I think one of the things too was that it was an older car and they don't have the give and the breakaway as the new car. These are solid. They are steel.
They're little
There's
tanks,
no
yeah.
good with those. But when he came in, and because, I mean, we do play armchair quarterback a little bit, but I was in there with him. You could see he was in obvious distress the minute.
Flip
he
back
came
to
in.
his x-ray. Yeah. So this is actually something we do here, but he had so many other injuries that we couldn't do it. So the younger lynches will do rib plating here. This is amazing to think about it being such a simple procedure. So otherwise, all of these are in pieces, and it's no different than hardware in any other part of your body other than it's made for the ribs. So this is like it reminds me of a Connex. Remember Connex when you were little and how they have the little brackets that you would use to put your stuff together? That's what this looks like. And then these are like little grommets that go in, and then they secure these to these. And so he has 1, 2, 3, 4, 5 right there. So,
Like I said, you would think it would just, you just go, ooh, looking at it, but
and I'm
it honest to
wasn't.
God helps their pain.
Yeah.
It's amazing, so,
That's a good case.
okay. Anything else? All right, we'll move along because we got a lot to do. The second case, this is a 21-year-old female. She was called down 20 stairs, went in cardiac arrest. 911 call came in at 16:48, dispatch 16:49, en route at 16:57.
All right.
This was an outside county, I don't remember. I couldn't find a reason why. On scene at 16:57, so that may have been I mean, this was on their sheets.
We have one or two that is pretty dependent on volunteers, is the only thing I can
Yes.
think of, is that maybe they had to wait for personnel.
Yeah, that's thinking that's what it was. They departed the scene at 17:13, Union ER 17:29. Call dispatch was 1 minute, dispatched en route was 8. On scene to arrival was 0 minutes, they were like within a block of them. On scene to departure 16 minutes, departure to arrival 16, so total call time was 41 minutes. All right, so this was they were dispatched for a 71-year-old female who had a fall down the stairs. They were advised while they were en route that she was CPR in progress. So they found her supine at the bottom of the stairs in a narrow area. No vitals. The monitor showed PEA 61. GCS, of course, was 3. She was cyanotic, pulseless, apneic. So, and CPR was being done by the fire department. They put in a number 4 iGel, a ventilator, and the entitle was in place. Let's see. Absent pulses during the pulse check. They put the Lucas on her, continued compressions. Put on pads, IV, normal saline. Next check, still no pulse. She was still PEA. They gave her epi and continued CPR. At 17:10, she had a jump in her entitle. Heart rate showed 131. She did have a pulse. She was attempting to breathe on her own. Ventilations continued. Their EKG interpretation was right bundle branch, and her pressure was 125/65. They placed her on the cot, put her in an ambulance. She was on the backboard and had a C-collar, I believe. Monitor 4 lead, IV saline and C-collar. Blood pressure dropped again to 90/60. They put fluids on the pressure bag and pressure came up a little bit to 107/39. Continued the ventilations and called the IHERN with the trauma and post-arrest alert. Came to Union Terre Haute ER. On the, let's see, pre-arrival said that she fell down 20 to 30 stairs. Pressure, she had CPR. Pressure was 90/60. Heart rate 104. SAT was 98 with the iGel. Entitle was 38. She had a C-color. They called a level 1 at 17:25, and the surgeon arrived at 17:34. Vitals on arrival is 35.9. Heart rate 107, rest 16, as 98% with an LMA. No obvious trauma, but had significant mechanism. That they weren't sure if there was some kind of medical cause that caused her to fall down the stairs.
Probably the cardiac.
She was intubated at 17:38. They had to reposition the tube, it was down the right front. She had a urostomy, GCS was 3. Pulse was obtained by EMS prior to arrival. They started 2 IVs, started norepi, gave fentanyl and saline. Her labs, of course, what you'd expect. CO2 content was 15, GAP was 19. Creatinine was 1.36, glucose was up a little bit. Her liver enzymes were up, lipase 75, lactate 6.8, TRP was 24. Alcohol was negative. They did type and screen, ABGs 7.284, PCO2 is 35, PO2 363, and bicarb 9.5. The C-spine showed slightly comminuted fracture of the right anterior and mid-arch and the left posterior arch of C1, Jefferson fracture. Bilateral apical pleural fusions dependent densities and opacities, likely because of the trauma. And then the chest tube, they just had to reposition it because it was in the right bone. CTA of the chest, again, talking about the opacities because of the trauma. She had fractures involving the right anterior, second through seventh rib. CTA of the head, chronic white matter changes. CTA, the chest, abdomen, pulse, pelvis was just talking about the rib fractures again. EKG was junctional left bundle branch. So her diagnosis was C1 fracture, multiple fractures of ribs, bilateral pulmonary contusions, fall, cardiac arrest, AKI, metabolic acidosis, and then her elevated enzymes. Care was coordinated with trauma. They contacted St. Vincent and they accepted her for transfer. She was transferred to St. Vincent in the 1930. Total ER time was 2 hours, 4 minutes. So just a few minutes over our time. I tried to get the best film of this I could, and this is why I pulled this, just because we don't see a lot of just C1 fractures. So when I had them look at it for me, they're kind of pointing to over here and then down through here. Is that what you're seeing, Dr. Worley? I got a good picture. That's hard for you guys can just scan through it. I'm like, that kind of looks like it. Me and Trent were both.
I know white and gray are bad.
Doing this. 10 millimeter shift for me to see something, but anyhow, that's the Jefferson fractures. You have the front and the back, right? So I just wanted to show you that because we don't see, we don't see a whole lot of those, just the
So
C1.
this one, you really can't decide, did she have an arrest and fall and broke her neck? Or did she fall and break her neck and it caused the arrest?
Yeah, so
Because
they-
nothing really gave us enough information one way or the other. So that's why a lot of times they cross over. So you're like, oh, well, this is, a cardiac arrest. This is cardiac. This is Will's specialty, but you don't know it.
You don't know
They do
for
cross
sure.
over. And stroke does that a lot too. You're like, I don't know. I think they had a stroke and fell. Probably, but did they have an injury from it? So this is a good case that shows how they cross over.
So we did get some, we did get some follow-up on her. We asked for the follow-up and she was up there for 3 days and never did respond to anything they did. So finally the family did a terminal wean 3 days later and she passed. And that's all I got.
Thanks very much.
Thanks.
Appreciate it. Well, we had a case presentation that was supposed to happen and Chris isn't here, so we're gonna skip through this one. It was a really good run, by the way. That's the reason why I asked him to do it. So hopefully if he doesn't, we'll get him to come back and do it another day.
COVID days without a mask on.
And then we were supposed to have a guy named Tyler Cruz who works for an IR company that does DVT and PE removals. And he was gonna come today. He actually sponsored breakfast for us today. He was gonna come do a presentation, but he had to stay in Indianapolis for 2 cases over there. So we're gonna skip through him. And so Dr. Worley, you are up. Is that you?
No.
That's what I thought.
Looked good though.
Huh?
Looks good though.
Yeah, he has some good stuff, so. All right, Dr. Worley's gonna do a pulmonary EMS review for us.
All right, we'll need to do a quick, review studies that, okay, thank you. All right, so, the initial, presenter was gonna kind of focus a little more on treatment. So this is kind of more heavily in presentation and, the ED workup of PE. So first of all, a little bit about pulmonary embolism. It is a very high mortality condition. It affects many hundreds of thousands of people a year, and a third will die. So 33% of people who have a PE will die from it, which is pretty impressive. And it is part of a spectrum of what we call venous thromboembolic disease, or VTE, which is actually the third most common cardiovascular syndrome after MI and stroke. Does anybody know who this is? Well, right. This is a little harder one. Does anybody remember who this guy is? So this was David Bloom, who was the chief international correspondent for NBC during the Iraq War. And what binds these two together is they both suffered from PE. Dan Quayle had a PE in 1994 and was in the hospital for a couple of weeks. but obviously survived. David Bloom was 39 and he actually died from his PE. The common factor that caused both of their PEs was immobility. Dan Quayle had been on a long plane trip. David Bloom had been covering the Iraq War and so was like in a tank or some armored vehicle for an extended period of time, which caused their PE. So how does a PE occur? So obviously it begins with the clot, and typically the clot starts in the lower extremity veins. Now, it can also start in the upper extremity too, but that's less likely. Portion of the clot gets dislodged, travels to the heart, into the pulmonary vessels, and finally to a point where it no longer can pass through any smaller space and starts to build up from that point. So this causes infarction of the lung tissue, and that's kind of what causes that sharp pleuritic chest pain that you commonly associate with PE. It's sharp, kind of focal, worse with a deep breath, that sort of thing. And then at that point, depending on how much lung is affected or how big the clot burden is, they become hypoxic, increase in respiratory rate, and kind of you find the other physical exam factors that you might normally see in PE. Now, the thing to remember is if a clot is big enough, it's going to impact the entire pulmonary circulation before it can cause an infarction. So not everybody will have chest pain with a PE because some people become symptomatic or die with a PE before they even have time for the lung to infarct if the clot is big enough. So you can't talk about PE or VTE without Virchow's triad. It's the triad of factors that cause blood to clot. First is hypercoagulability. So that can be cancer, some sort of thrombophilia, like a genetic predisposition to clotting, or it can be caused as a result of the second of Virchow's triad, which is stasis of blood, and that is from usually immobility in our case, and then also vessel wall injury, which again can be inflammation from immobility or surgery or some sort of chemical irritation. And that triad is typically what leads to the clotting of blood. So again, typically occurs in the lower extremities and then travels to the heart, into the lungs until it reaches the point where it can no longer pass further. So what are the cardiac effects of PE? Initially, the patient will become tachycardic because of the impaired blood flow. The pulmonary resistance will be impaired, which then causes the right ventricle to enlarge. You'll hear a lot in PE about right ventricular failure or right ventricular strain. That's basically because the right ventricle is pushing against the pulmonary resistance, which is now much, much higher than it normally is. Eventually then the right atrial pressure will rise, the right ventricle will fail to produce enough blood to the pulmonary circuit. And this causes what we call acute cor pulmonale, which is right heart failure and then ultimately cardiogenic shock. So this is kind of just a representation of that whole process. It starts with right ventricular dilatation, and then you go down through tricuspid valve insufficiency, and then you have a whole bunch of neurohormonal influences within the pulmonary vascular system that kick in, that cause vasoconstriction and the like. Leads all the way down to decreased RV contractility, which obviously increases or decreases your right ventricular output, and that affects the entire rest of the systemic circulation, and you get this spiral of shock towards death. So what are the risk factors for PE? Who do you need to kind of keep it in mind for particularly? The first thing is someone that is hypercoagulable, someone that is more likely to clot. So cancer is a huge cause of hypercoagulability. Really any type of cancer increases your coagulability. So it should be on your radar for anybody that's got active cancer. Pregnancy or postpartum is a big one. Exposure to hormone therapy. So getting a med list to know if someone is on hormone therapy like estrogen or testosterone for any reason, or if they know they've got a history of a clotting disorder, obviously. So what does immobility mean? Because that is a risk factor for PE. Basically bed rest for more than 24 hours. So especially think about it with like a recent major surgery, especially lower extremity fractures, joint replacements, that sort of thing. Long car trips or plane trips, typically, more than 4 hours or so of sitting in one position without getting up and stretching and moving around. And then obviously paralysis, think about it in your patients that, are paraplegic, quadriplegic, those sorts of things. So what symptoms do you look for to diagnose or at least put it high on your radar? Dyspnea is the big one. That's the most common complaint in PE. Phleuritic chest pain is the second, but depending again on where the clot and that infarction is, if they infarct like low in their right lung, they may present with right flank pain, and you might think, oh, this is a kidney stone, or this is just musculoskeletal pain. But if they've got any of those other factors or any of those vital sign findings, or something just doesn't add up, remember that PE doesn't necessarily have to be just anterior chest. It can be chest, flank, and anywhere above the diaphragm, basically. You may have lung findings. So typically we think, okay, someone that's short of breath with clear lungs, think PE. But also remember, if they've got a lung infarction, you may hear crackles or wheezes in that area where the lung is infarcted. Hemoptysis is a big one. It's not very common, but if it's there, it helps point you in that direction. Think about looking at the extremities. Some people have no self-awareness, as you know, and you'll say, well, anything else going on? And they'll be like, no, and you'll look and their right leg is 3 times larger than their left leg. And then obviously your usual signs of cardiogenic shock. So let's talk about your EKG findings. You hook patients up to the EKG, what do you find? There are a couple of things on this EKG, but what maybe strikes you when you first look at it? Tachycardic, yes. So you look at it immediately like, oh, this is fast. So tachycardia is the most common EKG finding. I guess I should say the most common abnormal EKG finding, because actually the majority of patients with PE may have a normal EKG. But tachycardia is the most common, 44%. So here's another one. And again, there's some few things going on here. Anyone want to take a guess at this one?
YQRS.
Is that like a blood pressure?
So wide QRS, I heard right bundle branch. So yes, both of those are, the wide QRS kind of goes with the right bundle branch. Yes, that is, both of those are findings of PE, but particularly in this EKG, if you notice how you've got this large S wave in lead 1, this Q wave and inverted T wave in lead 3, that's the S1 Q3 T3 pattern that comes with right ventricular strain. So that's kind of a very pathognomonic finding in PE, is that S1 Q3 T3 pattern. But again, it's not overly specific. You can see it in just right heart strain from other reasons like pulmonary hypertension, and you can certainly have a PE where you don't see it. But if you see that, S1 Q3 T3 pattern in the right circumstance, think about it. So 20% of the time, they say. So again, bundle branch block, right bundle, 18% of the time. And then right axis deviation is another thing that you'll see about 16% of the time. And then what about this EKG? What is this rhythm? Irregular. So probably AFib. Yeah. So atrial tachyarrhythmias are not uncommon with PE, 8%. So, and then other things you may see, just a large R wave in V1. right atrial enlargement, and just 50% of the time you'll just have non-specific changes. So what does right atrial enlargement look like? Basically, these big P waves in your inferior leads. So if you see that in the right setting, consider PE or at least right atrial dysfunction. So treatment, obviously you're going to treat the hypoxia, high flow, oxygen. If the patient is hypoxic, you're going to treat hypotension with crystalloid infusion. But again, you want to be cautious because you don't want to overload, their pulmonary circuit with more fluid. But you shouldn't have to worry about that, with, the typical scene and transport times. And then vasopressors if needed, if they're hypotensive, not responsive to fluid, norepi is a reasonable choice. So what do we do when a patient comes to the ED for PE? So the first thing that we ask ourselves is what is our suspicion of pulmonary embolism? And we can do this a couple of ways. We can just use our gestalt, which means, what do we think? Looking at the patient, or we can use what we call a prediction rule, which we'll talk about in a minute. But we come up with a decision in our mind, is this patient low risk or high risk of PE? If we think the patient is high risk, like we look at this patient and we're like, I 50% think this patient has a PE, we're gonna go right to a CT pulmonary embolism study. If we look at the patient and we think, maybe they're low risk, then instead of going right to the PE study, we'll get a D-dimer test. You probably have seen quite a bit of those when you're, especially like if you transfer patients from one hospital to another and that sort of thing. So the D-dimer, if it is then negative in a low probability patient, we can rule out PE and not ever have to do the CT PE study, because the thing with the CT study is it's a lot of radiation, and obviously you want to avoid that if you can. So what are our decision rules? How do we decide who is low risk versus high risk? Most of us use what we call the PERC criteria, or the pulmonary embolism rule out criteria. So basically, it's an all or nothing sort of thing. If a patient meets any of these criteria, they are PERC positive, and you cannot rule them out for PE without getting a D-dimer. But if a patient meets all of these criteria, so they're under 50, their heart rate is less than 100, their SAT is 95 or above, they have had no recent immobility, they're not on hormone therapy, no prior history of VTE, no hemoptysis, no unilateral leg swelling, they meet all of that criteria, we're done. We don't have to think about PE anymore. But again, if they meet any of these PERC criteria, our next step is to do a D-dimer. The problem with the D-dimer, it's very sensitive, meaning it's going to pick up, all of your clots, hopefully. The bad thing is that it's poorly specific, meaning there's lots of false positives. So you're still going to end up, scanning a fair number of people by getting the D-dimer. So this is just an example of a CT PE study. So here's the heart, here's the pulmonary trunk, and the right and left pulmonary artery. This is blood here, so all of this should be the same color, but you see this large clot through here and down in there and down into the left pulmonary artery and the right pulmonary artery. This is a bad PE. This is what we call the saddle PE that kind of crosses both right and left pulmonary arteries. Probably this patient is going to be pretty symptomatic. Now, you might be surprised, not all are, but usually these patients are, hope he gets better. So, this is an example of smaller PE that might be less clinically significant. So here, pulmonary trunk, pulmonary arteries are nice and wide open. These small arteries look good, but down in the smaller arteries of the right lung, you see those filling defects, that's all clot there. That patient may be a lot less symptomatic, but they may also have a big clot in their leg that could break off in an hour and lead to a saddle PE as well. So what do we look for with labs? We look for signs of right heart failure because that kind of guides our treatment. If a patient looks stable and they have no evidence that they've got right heart strain, it's much less serious than a patient that exhibits signs that they have cor pulmonale or impending cor pulmonale. So we look at labs. We look for an elevated troponin, elevated BNP, which would indicate that they've got right heart strain. So what about the treatment for PE? So first of all of these patients are going to be anticoagulated, mostly with heparin. We used to sometimes use Lovenox, but really heparin is nice because you can follow how effective the heparin is by following a patient's PTT level. And also heparin has an antidote in case for whatever reason you need to reverse the patient's coagulation. So most everybody is using heparin these days. So if you're a transferring unit, you'll transfer these patients likely on a heparin drip. And then it comes down to whether a patient is hemodynamically unstable or not. So do they have severe hypotension? Are they hypoxic on room air? If any of those sorts of things are present, then you consider reperfusion treatment, which is kind of what the initial presentation was going to be about. That means consider getting them to a facility that can do interventional radiology or interventional cardiology, where they can actually go in and suck out the clot, basically. Now, the other option here is if you have a patient that is coding or pericode, you can give these patients systemic thrombolytics like you do in MI, like you do in stroke. But we typically reserve that for those peri-arrest or arrest situations because that then limits a person's ability to go in interventionally later. Now, if someone is not hemodynamically unstable, it's possible they may even be able to go home. It used to be we admitted every PE, but someone who's not hemodynamically unstable and who meets a host of some other criteria may actually be able to go home. But the big key with this slide is hemodynamic instability means they need some sort of reperfusion therapy. And again, systemic thrombolysis, typically reserved for the severely hemodynamically unstable. Sometimes you'll have a patient in cardiac arrest. It's a young person. You don't know why. Like maybe it's PE. As a kitchen sink, you can give them, a dose of thrombolytics. It isn't hugely efficacious as you might imagine, but dead is dead. And you're not going to make them deader. So then there's again the interventional therapy, which includes like catheter directed thrombolysis, where they actually go up with a catheter and can squirt the clot with thrombolytics. But now more and more, the traditional treatment is now thrombectomy, where they actually just kind of go in and suck out the clot from the pulmonary artery. And I believe some of the cardiologists may do that here, not all of them. But like Methodist, St. Vincent's, they all have, dedicated like level 1 PE protocol for this sort of thing. And then everyone is essentially anticoagulated. So what are your long-term concerns for people with PE? The main, if you survive, which is great, your main long-term concern is pulmonary hypertension, which can be a very debilitating disorder. If you've ever seen anybody with pulmonary hypertension, sometimes they're on long-term oxygen, sometimes they're on continuous infusions of prostaglandins and that sort of thing to help keep their pulmonary vasculature open. It can be a very, very debilitating disorder. Obviously, someone who is on anticoagulants has a bleeding risk, and then they may have a genetic hypercoagulable state that will put them at persistent risk of PE. So again, who can we discharge home with PE? This is what we call the PESI score, which is a series of different things where you kind of add up, it's a point system. So, if you've got someone who's 30 years old, who doesn't have cancer, who doesn't have heart failure, whose stats are 100%, and they've got a single little solitary PE, they don't have to be admitted to the hospital. We can put those patients on Eliquis or Xarelto or Lovenox, and they could be discharged home to follow up. This is another criteria for discharging patients home called the Hestia criteria. Basically kind of has some of the same things. Obviously, you're not going to send someone home that needs a thrombolysis or that is needing oxygen and those sorts of things. All right, so that is it. Any questions about PE?
Did I catch that right at the beginning, that it's a 33% mortality?
33, I checked that a couple of different places, and yeah, every
I just think back over the years, the number of PEs I've seen, and
Yeah.
granted, we're in the ER, so you don't see like the back end of a lot of this, but
Yeah.
I just feel like I would have heard of more people passing on.
And it'll be interesting. I assume that data is fairly new. I mean, obviously, back in the old days, we didn't find we just had VQ scan, like before we had CT.
Yeah.
You know, you missed a lot of PEs just because not everybody can get VQ. Now that CT is so prevalent, we may be diagnosing more and we may see that number fall. But that's still a number.
Wow.
Thanks, Zach. Appreciate it very much. All right, guys, for those of you online, here's to fill out the form for continuing education hours. There's a link and a QR code. It just has simple questions, name and out the PSID number and that kind of stuff. We'll be meeting November at regional. Ryan wanted me to mention, he's putting on a EMT refresher course that will be going from November 4th through November 7th. Reach out to Brian, or we're gonna put flyers out to everybody for that, and I've got some flyers out. Reminder to everyone, please come join us here October 31st. And I believe that one was at 10 o'clock. In the atrium, we're doing a pharmacology review from aspirin all the way through narcotics, so it'll hit every level. Really oxygen, the whole works will be really good. It's some extra continuing education hours for you. The only thing that'll be required for you is just to answer a couple of survey questions for me, just because it's part of my 2024 EMS goal for the hospital. But it's gonna be extra free hours for anybody that needs them. And we're doing another one on November 13th. It was scheduled to be in here, but that's when our magnet site visit is. And so we'll be moving it to the gray room, which is the west building, building number 2 in the lower level. You go down the stairs, it's right around the corner, right past the chapel through these double doors. It's on the left-hand side. It's really easy to find. I'll put some signs and stuff out that day. But October 31st at 10 a.m. here in the atrium, they'll be doing a pharmacology review for continuing education hours for free. So
Will there be a virtual option for it?
yes, there's a virtual option for the one in October 31st. The one in November, there's not, because since we've been taken out of this room, we're at the gray room, it's face-to-face only. So I'm hoping to fill that room. That one there is going to be a 12-lead course from helping at the EMT level to put the 12 lead on, and then Kim Bumgarner is going to be putting that one on for us.
Not for the 31st, since there's gonna be an online, will that be an option to like go back and like review it, like if you?
Yeah, I'll have it
absolutely
recorded.
can't-
I put it up on YouTube. Yeah, I put my other one
So
up.
can you watch it and then like do the review questions after and still get credit
Yes,
for it
yep.
at a later date?
Yep.
Awesome, okay.
Yep, we'll do that. So
Cool.
for sure. Any other questions from anybody? Have a great day. If you hadn't signed in, please sign in, and there's breakfast back there if you want some. Otherwise, I'm gonna take it up to the ER.
Family day.
Thank you very much for everything.
Boy graduated.
I'm gonna leave that up just a little while longer. I'll.